I think you hear me. All right. Morning. So both of you, thanks for great talks. Ellie, I have first question for, well, actually, I guess it's a question for both of you, is really sort of the question that always comes up about the challenge of vaccinating naive patients versus people who've been infected before. And I guess that seems to be more of a challenge for the T-cell approach, just with the question, we don't see too much reversal of exhaustion when you treat people. So are you concerned that you're going to have exhausted T-cells that will just not respond when you vaccinate them after treatment? And I guess the second question, which relates to it a little bit, is just about whether genotype is really the right thing to look at for diversity, because particularly when you're focusing on the surface, it's really not very genotype. The genotype is not that predictive of how much variability there is in E1 and E2. So I'm just wondering why there's always the focus so much on genotype when you're looking at protection, because if you look at your vaccine prototype, your protection against genotype 6 was better than against genotype 1A, even though it's a genotype 1A vaccine. So just thoughts about those two questions. Thanks.
You want to take the T-cell question?
All right, well, I'll take the T-cell bit, and then John can take the envelope bit. So will there be an issue in vaccinating people that have had chronic hep C and had DAA therapy? Okay, so we have vaccinated some patients now, 6 patients who had DAA therapy with our genetically adjuvant vaccines. And actually most of them make really decent responses, T-cell responses to that vaccine. So that and the data that I showed where some people can make a really good T-cell responses tells us that not all the T-cells are kind of exhausted, but the ones, it all comes down to the issue of what strain were they infected with when they were infected, I think. So I think it will be very hard to induce kind of T-cells against the strain that somebody was first infected with, even with the most potent T-cell vaccine.
Do you think they'll actually be protected better for heterologous challenge than homologous challenge? That's interesting.
I don't see why they wouldn't almost be completely protected from heterologous challenge. So a vaccine would have a role in those people, but it wouldn't be like vaccinating a naive person where you may prevent infection from any incoming strain where exhaustion wasn't an issue. But it was really illuminating to me when we vaccinated those chronically infected people the first time and showed how hard it was to kind of induce T-cells in some of those people. And the fact that they've had kind of DAA therapy, there are papers out now which suggest that DAA therapy can restore your T-cell immunity. But yeah, it's really subtle if true at all, I would say. There may be some marginal improvement, but they don't go back to healthy T-cells like a naive person, that's for sure. So that's the answer to this question.
Yeah, I guess for the cross-genotype, I agree with you is that our goal is to neutralize all different viruses. Perhaps the genotype line is just a imaginary line that's provide the most diversity. I think eventually we have to test them. One thing we want to highlight is that obviously there's variability of different neutralizations against different viruses. We don't know exactly how much protection you need to confer that. Our goal is you can maximize the protections, and perhaps then you can sort of take care of that. And I think that's sort of where the combination approach is very critical, is that the antibody could delay the infections, and perhaps then you require a cellular immunity to prevent subsequent or residual infections that could take place. So I think that. And just the first part of the questions, I guess currently most of the vaccines are intended for prophylactic use, and I think there's still a lot of work that we need to somehow boost the immunity in order to test it in a therapeutic use after the initial clearance of the virus to prevent reinfections.
Vanessa? Thanks. I don't know if this is on. Okay. Thank you both, first off, for 2 great complimentary talks on the background for the different work that you're doing with vaccines. 2 questions, so one for each. I'll start with Dr. Barnes. I'm reading a little bit and learning a bit about the hydrodynamic injections, like you were talking about using the tail vein injection to increase the time that the vaccine spends in the liver. Is there a presumed benefit to that in the Hep C infected population? I mean, if you have a T cell response, is there any benefit to having the T cells come to the liver specifically to interact with those antigens in terms of, if the patient doesn't get exposed to the infection, say, for 5 years or 10 years?
Yeah, I mean, okay, so it's not really hydrodynamic tail injections. That's a high pressure thing where you kind of drive something into the liver. It's just the intravenous injection, which and these kind of vectors naturally home into the liver. It just makes kind of sense to have your T cell sitting there in the place where they're going to be most required to rapidly induce their effector function. That's all. So I think if you manage to enhance the number of T cells sitting in the right place, you're just another further step ahead. You haven't got the maybe the 1 or 2 weeks that it would take to induce a proper memory response and get those into the right place. So I think it could be better. You have to balance that against the lack of the kind of practicalities of giving people intravenous injections widespread for a vaccine program. I mean, that's actually means it can't be done by many healthcare professionals. So there's a big downside to the approach. But
it's an interesting idea. It's a novel approach to
idea, I think.
Having more exposure to the antigen in one spot. I think it's interesting.
Yeah. And it definitely works in malaria challenge models. So if you take the malaria mouse parasite and you use an IM-IV approach so that you get malaria-specific T cells in the liver, and then you infect those mice with malaria, the kind of studies we can't really do with Hep C, those mice are completely protected. So there's kind of proof of principle that it can work.
Yeah, that's great. Thank you. If you don't mind, thank you. So my other question was for Dr. Law. So it's regarding the epitopes, and we have, just looking at the whole class of flaviviridae, we have vaccines for Japanese encephalitis, yellow fever, and dengue, plus or minus that one, as well as in the vet world, we have a lot of BVDV vaccines of various ranges. So of those other flaviviridae that we have vaccines for, are you aware of, or are you familiar with any of the other epitopes that have been used and have had success in those other collections?
For example, I guess the yellow fever vaccine is very effective and it confers great protections. I think that probably to do with more the virology of the virus. For some reason, XCV might actually just doesn't replicate as quick, doesn't induce as much immune response, and perhaps there's a delay on the natural immune response during the wild type XCV infections, and perhaps that's make the immune response not as good compared to yellow fever, for example. I think the approach is similar, and I think there's maybe more variety or diversity in XCV and make the antibodies a little bit difficult to protect. But in yellow fever, for example, I guess the diversity is much less, so the antibody that they raise by their vaccines are much more easy to neutralize. I don't think there's a direct comparison of the epitope that induced by these flavivirus vaccine compared to the XCV vaccine, just because I think XCV seems to have boatloads of variety of immune escape mechanism, even just on the glycoprotein size to prevent the antibodies to work. We didn't touch on this. Elias mentioned that the HCV glycoproteins has a lot of hypervariable regions to diverse the antibodies to those decoy areas. So that's might be one of the possible difficulty.
Yeah. Thank you.
Yeah, the very effective yellow fever vaccine also induces very high kind of T cells of yellow fever, CD4 and CD8 T cells. It's probably good because it actually does bring together B and T cell components.
Thank you. Just a quick question. So Carla Coffin from University of Calgary. Just as along the same lines as what Vanessa had mentioned, I've sort of joked to my colleague who worked on BVD that we can't do the same thing with cowpox as what Jenner did with the smallpox vaccine. But my question is actually for Dr. Burns. In your vaccine studies with the Oxford students, and you noted that with the second boost that they had a poorer response because likely from pre-existing adenovirus antibodies to the first vaccine dose. Yeah. Was any of this impacted potentially by a pre-existing natural infection with adenovirus? I know that this has come up as an issue with the therapeutic T-cell vaccines for hepatitis B. like
Yeah.
in people that responded?
Yeah, so you can measure those in quite complicated kind of cross-neutralization assays, and we have done that in the past. So you can measure your pre-existing anti-adenoviral titer. You can look at the cross-reactivity of that with your vaccine as best as you can in these in vitro assays, and then you can try to kind of correlate your pre-existing antibody level with the. And I mean, the bottom line is with the chimp-3 vaccine, that about 3% of people do have neutralizing antibodies. So it's a very low percentage, but there is a small subset that have those. And from our data, I think when your titers of pre-existing antibodies get above quite a high threshold, I'm sure that can block responses. But at a low threshold, it seems to have kind of no effect. So I do think they kind of matter, but they're pretty rare and that's why those particular vectors have been selected from that very large panel that I showed you on that phagocytic tree.
Yeah.
I mean, at the outset, there was a lot to choose from, and the choice was made on the basis of the immunogenicity of those constructs when tested in kind of mice and the amount of pre-existing immunity that seems to be in human people. That those kind of factors were used to select those vectors.
Thank you.
Thank you both for those great talks. Sophia Bartlett from the BC Centre for Disease Control in UBC. This is a kind of philosophical question, but if the best vaccine for hepatitis C that we can hope for is probably not going to confer complete immunity and people will end up with an acute infection, which they then are more likely to clear, we probably can expect that the period of time when someone is acutely infected is when they're at the greatest risk for transmitting hepatitis C. So I'm just wondering if there's any thought or modelling around what type of vaccine coverage you would need to have, because if people are still able to transmit the virus when they're acutely infected and they've already been vaccinated, that kind of maybe suggests that we could end up with continual transmission in a vaccinated population. So I'm just curious whether that's a question that is being considered, and do you have any idea about what type of vaccine coverage you would need in that scenario?
Yeah, I mean, I think the modelling is really important, and there are people working on this, but there's not huge amounts of hard data, I think, because of the lack of kind of vaccine data. I think for an antibody-based vaccine, actually that could potentially block, if you had the right antibodies there, that could actually kind of neutralise. It could be very quick. Mm-hmm. So I mean, that's how our current vaccines work. They block infection completely. That's not true for a T-cell vaccine. For a T-cell to be induced, you have to have infection because the antigen has to be. So you have to have infection for a T-cell vaccine. But I mean that can be very kind of quick. It can be in a matter of weeks, like 4 weeks potentially. Mm-hmm. So I think it can be fast. And it would be really interesting to model actually whether 4 weeks, 8 weeks, 12 weeks, 1 year, 2 years.
Yeah, like what's the minimum amount?
What's kind of minimum?
Yeah.
And that would be really interesting kind of work. I'm not aware of anyone who's working on that. It would be a nice position to be in where we had a vaccine that worked, where we then need to model that.
Yeah.
That'd be a great position to be in. We're not really there yet.
Thank you.
Yeah. Did you want to add anything to that?
I think there's a couple of things I'd like to add. Yesterday, I think Dr. Martin has shown us a little bit model about HCV clearance, and I think she used a example of treating patients as a prevention strategy, and that have dramatic impacts on eventual clearance of that. I guess in some way, obviously I argue that our vaccine will be better than treating a patient with DAA, but I think based on the modeling, it will be similar. That you take out people that actually can shed the virus, and so perhaps then you will make it more effective in terms of prevention. Your idea might be correct, is that it do not prevent acute infections. They might still have a chance to spread the virus, but what I argue is that instead of spreading the virus for 20 years, hopefully they're spreading for virus only 1 year or 2 years, and perhaps there will be some benefits to it. And then some modeling has done to what's the role of vaccines to do in terms of preventions. I think even as low as 40% effective vaccine can have a dramatic impact in terms of the clearance of HCV, and hopefully our vaccine will be better than 40%.
Coffee back.
Just out of curiosity, are the slides available anywhere?
Are the slides available?
Yes. Presentation slides?
They actually filmed the whole presentation.
It's all
I don't know
filmed.
who
Sorry.
It's all being filmed, so I think they're going to be. I think the whole.
Okay.
Yeah. Wait. Yeah.
I really enjoyed both your talks. Thank you. So we know that most people are cured the first time round with DAA therapy, but we do have a collection of patients who are unsuccessful with their first round of therapy. I think we understand that it's a combination of the antiviral effects of the DAAs plus the host's own immune response that helps to clear the virus. So is any of your work or anything else happening looking at the combination of repeat DAA therapy plus immunization to try and boost the host immune response in an effort to clear these difficult to cure patients?
Yeah, I mean, I think the difficult to clear story is still being worked out now. So we've got some data now from the UK. We're presenting it at EASL in next month in London, where we've looked at all the people across the UK that received pan-genotypic first-line DAAs failed, which is a number of about 250 people we have who were then retreated with soft Valvox. And we've been really surprised that for genotype 3 patients with cirrhosis, the SVR rate's less than 80% in those patients retreated with soft Valvox.
Yeah.
So I think there's really important resistance that we're going to see, particularly in genotype 3 still, and then in these rare subtypes that are emerging as being inherently resistant. So that's like genotype 3B, 1L, 4R. There's these pockets where the wild type amino acids in NS5A are resistant variants for those kind of subtypes, and these are in really poorly studied populations at the moment. So I think this is going to be this is a thing we're going to see much more of in the next 5 years. But I think all that data is going to have to come out before anyone's convinced we need combination strategies to kind of deal with them.
Okay, great. No.
And then we're going to be stuck with these kind of resistant strains. I mean, I think that's going to happen.
Yeah.
But, that's my view, having looked at this kind of data.
Yeah, due to the time, maybe one question, yeah.
It's a quick one. So that whole liver, I'm Lisa Barrett from Dalhousie. It's an interesting thing, the liver environment and immunity. And you guys have talked about two sort of big populations of cells that are important. With emerging interest and evidence around NK cell education and the ability to adapt them and their important role in the liver, do you think there's a role to look at including within an effective vaccine for Hep C some sort of NK education type of target?
Yeah. So
I only want B cells, so.
You only want B cells? I mean, the NK CD8 T cell. There's an intimate NK CD8 T cell relationship especially in the liver that's been very nicely shown, hepatitis C and hepatitis B. So I think the answer is yes, but I don't know how to do it practically. So maybe you could tell us how we can a kind of practical solution to doing that in a vaccine strategy. It should definitely be explored. I just wouldn't know how to start. So do you have any ideas? Okay.
No.
It's a discussion. I mean,
Yeah, for after, I think it's just, we always think of T and B cells, and we kind of leave out the NK cell bit. And as it becomes more adaptive in its nature, I think as we learn about it, it's an important thought.
I think one thing that we probably touch on is that there's still a role for adjuvants to kind of boost up these overall immune response, and some of these adjuvants could go through the NK routes and boost either side of the immunity. So in that sense, not somewhat a black box, we don't know what's going on, but I think powerful adjuvants could play an important role of increasing the immunogenicity of the vaccine.
Okay, thank you. So, join me, like, thank you, to a wonderful talk in the morning.